In this session, we're going to be learning about articulations. When we say articulations, we mean joints. So where one bone is coming into contact with another bone. Now, there's a whole lecture effectively on this, so you really want to have watched that lecture and try and understand as much as possible before moving on to this tutorial. It really all came down to this one summary classification table. This is a big key. You need to know how this works. The lecture spent 40 minutes just understanding what everything on this table meant. So I'm not going to go through it all again. Really watch that lecture until you understand it before moving on. But, just to really simplify, we had the structural class. So this is what the joint is made up of, and there was 3 different types of structural class. The types of joints refers to type of joint within those structural classes, and there's 3, 2, and then 6. Mobility, we had 3 different words. Diarthrotic, meaning freely movable. Amphiarthrotic, meaning a little bit of give, a little bit of movement. And synarthrotic, meaning no movement at all. Then in the axis of rotation, there was none for fibrous and cartilaginous. And then 6 options with basically 1, 2, 3, 4 options within these 6 because there's some double ups in there. So remember the non-axial, it's not referring to the amount of movement here because we've said they're all diarthrotic. Non-axial meant there's a lot of movement, but it's not rotating or pivoting around any axes. The uniaxials meant it's pivoting on one axis of rotation. There's normally 2 outcomes, so if I flex and extend my arm, right, there's 2 movement outcomes, flexion, extension, but there's 1 axis of rotation. For the biaxial ones, it's talking about 2 axes of rotation. So I might be able to, my wrist, for example, my radiocarpal joint, I can move on this axis, move on this axis, but I can't rotate it without moving my entire arm. So that's an example of a biaxial, rotating on 2 axes. And then multi-axial, rotating on all 3 axes. So my glenohumeral joint of my shoulder here, it can flex, extend, abduct, adduct. Circumduction, remember, is just a combination of those, but it's that rotation we're looking for, is that 3rd axis of rotation. So remember, all of these are freely movable. Don't get caught up with that non-axial meaning it doesn't move. It definitely does move. It's just not rotating around a particular axis. So now let's have a really closer look. Really, this column here, this type, is the key, because if you know what type it is, then effectively you know the rest. You can work out the table from here. So let's have a closer look of what each one of these types looks like. So now we're going to focus on the types of joints. So when we thinking about our table, we're talking about that column 2 in the table, so the types of joints. And you've got this space in your lab books to follow along and draw here, and I'm going to draw a picture of what each of these, an example of what each of these might look like, and then we'll go, and you can follow along and draw as well. So when we talk about sutures, we're talking about very, very short fibers, right? So the key here is short fibers, and we find suture joints common places in the skull. So if I drew a skull and you looked at the top of a skull, there's actually these little, almost like cracks or seams across the top of the skull. That is our suture joint. So small fibers, so small they're like fused together, is essentially no movement there. So they're called synarthrotic. That's why they were synarthrotic before. Now, syndesmosis, these are short fibers, these ones are long fibers. And an example where we see these are between the tibia and the fibula. So if I drew that's a tibia and this is my fibula, and to put this in context, I'll draw the foot in like this. Right, so here's my tibia reaching my foot, this is my ankle joint. Between the tibia and the fibula, there's a long fibered only joint there. That's called the distal tibiofibular joint. So these long fibers make it a syndesmosis joint. So far we've got sutures being short fibers, so short that they're fused together. The syndesmosis are these longer fibers, and being longer, they don't move like a joint you would think yet, but that longer just creates a little bit of give between them. So they're called amphiarthrotic. And the final type of fibrous joint is a gomphosis joint. So we're talking about the way that a tooth might fit into the gums. So the gomphosis, little fibers running around the tooth withhold it into the gum. And of course, gums, sort of, it's in the name, helps us to remember what they are. So these are short fibers too, these are synarthrotic, meaning no movement. So the good news here is these are the only type of fibrous joints that we're actually looking at in this subject. So where the cranial bones join together, they're suture joints of the skull. You've got the distal tibiofibular joint with the longer ligament attaching it, that's a syndesmosis. And then a peg and socket, it's called, where the tooth fits into the gum with the fibers all connecting around. That's your gum-phosis joint. Remember these fibrous joints, because what the distinguishing feature here is that fibrous joints only have fibers connecting them. So synovial joints also have fibers connecting them, but they've got other things connecting them. So rather than seeing some fibers on a joint and go, that must be fibrous, if you just remember these three and know what they are, then if it's not one of these three, then it can't be a fibrous joint. It's got to be something else. When we move to our cartilaginous joints, we've got two types of cartilaginous joints. We've got synchondrosis, we see that chron there, C-H-O-N, indicating that there's cartilage involved here, and symphysis. And for each, there's two types. So for the synchondrosis joints, these are the ones made out of hyaline cartilage only. And the first example we've got is where the first rib attaches into the manubrium of my sternum. So we have a little hyaline cartilage joint right there. So this is rib 1 joining into the sternum. That is a synchondrosis joint. Now I want to be really clear here that this first rib, which is the sternocostal joint, the first one is the only one that is a synchondrosis joint. Now, whilst we acknowledge that all the others also have cartilage, they actually have other things as well, so it's not just the cartilage combining them. But this rib 1, it's only the cartilage that combines my rib into my sternum, so it's the only example in the ribs that's a synchondrosis joint. There's one other one in the body, and it occurs at the end of all the long bones where the diaphysis meets the epiphysis. So right there, we see at the growth plate. So this is the head of a bone, this is the shaft of a bone. Between them, where the bone grows, we've got this hyaline cartilage. So that is another example of a synchondrosis joint. So synchondrosis joints, again, we don't really have the head moving from the shaft. We've already said that rib 1 doesn't move. Even with breathing, this is fairly fixed. So these are both synarthrotic joints. So there's only two types of synchondrosis joints, here and here. That's it. They're the only ones you have to remember. Now with the symphysis joints, these are joints joined via fibrocartilage. So if this is hyaline cartilage, this is fibrocartilage. And there's only two types of these as well. The first is at our intervertebral disc. So our intervertebral joints, where the disc, so this is a vertebrae body, this is a vertebrae body, this is a disc in the middle. This is two bones joined by fibrocartilage. So this is an example of a symphysis joint. So this is the intervertebral joint, between vertebral joint. So that's a symphysis joint. And unlike over here where we had these hyaline cartilage, was almost hard like bone where there's no movement, the discs, they're designed to have a bit of sponge, bit of movement, allow a little bit of give. So these ones are amphiarthrotic, whereas these were synarthrotic. Then we've got our pubic symphysis, and that is the space at the front of the coxal bone, where one coxal bone right there meets another coxal bone. So I draw them, these are my coxal bones there, do something like that. That's my sacrum and my coccyx at the back. These are my two coxal bones coming around. It's a hard shape to kind of draw. But right at the front here, we have what's called the pubic symphysis. This is also a fibrocartilage, joint. So this is a symphysis joint. So these are the only two symphysis joints. The pubic symphysis and the intervertebral joint are the only two examples of a symphysis joint. So if we look at this entire page, there's only 3 fibrous joints, and there's 2 lots of each of these, so 4 in total in our cartilaginous joints. There's only 7 to remember on this page. If it is not one of these joints, it must therefore be a synovial joint. Now the important thing with the synovial joints are that they also have fibers, they also have cartilage, and they have other things as well. They've got ligaments, they've got nerves and blood vessels, they can have you know, a synovial capsule with fluid. They've got all kinds of things. So if you see cartilage, don't jump just down here, it could still be in here. If you see fibers, don't jump over here, it could still be in here. Know these 7, if it's not one of them, it could be one of these. Now, easily the most common joints in the body are these plane joints, and they are everywhere. Plane joints essentially reflect where 2 bone surfaces come together and they're moving past each other. It could be like this, it could be like this, it could be like this, any which way. Nothing is like fitting in like a ball and socket or wrapping around. They're just 2 surfaces coming together. They could even be like that, even 2 surfaces coming together. So you see plane joints a lot. Some examples that we've already done from previous classes might be our carpal bones. Each one of these carpal bones, we said that Sally left the party to take out the home, we saw that group of 8, between every single one of those surfaces, there is a little plane joint. So plane, 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 plane. They're all little gliding plane joints. Right, so plane joints are found everywhere. Another classic example is for our vertebrae, these facets that were sticking up the top right there, every single facet in the body is another example of a plane joint. Because think about what a facet is, a little small surface sticking up, another one comes together on it and they rub past each other. So there's a bit of a rule. If you're not sure, you know, what the answer is, you pick plane because there's more of those than any others. There's literally hundreds in the body. All through the vertebrae, the rest of the ribs, where the rib touches the vertebrae, where the ribs touch the sternum, all examples of plane joints. Now hinge joints, there's only a couple in the body. There's sort of 3 notable examples. Example number 1 is our elbow. So if I draw my elbow, this is my ulnar sort of wrapping around. Sort of stuff this drawing up a little bit. Let's just start that one again. That's better, right, like that. Humerus coming down, ulnar wrapping around the humerus. Right, this is an example of a hinge joint. Right, so in a hinge joint, hinge joints can only flex and extend. So this is my elbow can only flex and extend. I also find hinge joints in my fingers. So this would be a hinge joint, my interphalangeal joints. That's a hinge joint, that's a hinge joint. The base of the finger is a little bit different because I can do other things. So hinge, 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 hinge. This is not. It's going to be something else. We also see a hinge joint at the ankle. Ankle's a hinge joint as well. Even though your feet combine to do a number of different things, the plantar flexion and dorsiflexion that occurs at your ankle is an example of a hinge. So your elbow was a hinge, your ankle was a hinge, and your interphalangeal joints are a hinge. They're the only example of hinge joints. That's all you have to remember. When we look at pivot joints, there's only a couple of those as well. A couple of notable examples here. We've got where your, let's say that's your ulnar again, and let's say this is your radius. Right here, at where the radius meets the ulnar, at the proximal radio-ulnar joint, that's an example of a little pivot joint. A ligament wraps around the head of the radius, connecting back to the ulnar, allowing pronation and supination to occur. It's the pivot joint at the proximal radio-ulnar joint that makes this possible. So there's a classic example of a pivot. Another one that we've seen before, may not have thought of, is where the dens, so this is C2, with the dens sticking up, and C1 is on top of it, pivots around. There's a little ligament that wraps around the dens holding C1 and C2 together. So this is the atlas, this is the axis. The joint between the dens there, the dens of one to the ring of bones of the other, is another example of a pivot joint. So between C1 and C2 and at the radio-ulnar joint. Another type of synovial condyloid joint is the synovial condyloid joint. So a condyloid joint is best to think about it like a ball and socket joint, but more of an oval. And it's a lot shallower, but similar to a ball and socket joint. So if I were to draw like a ball and socket joint, but imagine that is oval shaped rather than being a nice round ball. And the same on the other side, this kind of So shallower sort of socket. Here's an example of a condyloid joint. So it's looking like a ball and socket joint, but this is oval rather than being completely round. If I draw the ball and socket joint at the same time, I would draw like a rounder surface with a rounder. The ball and socket is a round surface fitting into a rounder hole. Condyloid is an oval surface fitting into an oval hole. Coloured with a few distinguishing features between these. So for starters, they can all both flex and extend, right? They can both abduct, adduct type movements. The difference between them is you can rotate a circle in a circle, but you can't rotate an oval in an oval. So look, I use my hands to describe this. If I had a ball and socket joint like that, and this is a circle, I could rotate it like that. But if these were two oval structures, an oval can't rotate in an oval. So distinguishing movements here, that's why these are bicondyloid, and that's why these are biaxial and these are multi-axial, because these don't allow rotation to occur. Now, your knee between your tibia and your femur is an example of a bicondyloid joint. So all that is two condyloid joints next to each other. So if we imagine the exact same thing occurring next to it, like this, and if I just replicate the same sort of thing down here. Now if I've got two condyloid joints next to each other, and I just draw over the top of that to make it, that's starting to look very much like a femoral condyle. And this is starting to look very much like a tibia, femur coming down and touching the tibia. So when we talk about the tibiofemoral joint, which is the joint of our knee effectively, not our kneecap, but our knee, we're calling that a bicondyloid joint. And bicondyloid joints are biaxial. They allow flexion and extension and a little bit of rotation, but they're different to a normal condyloid joint. And finally, we've got saddle. Saddle, we see just a couple of examples to remember. Number one, we've got your thumb. And number two, you've got your sternoclavicular joint. Now, rather than just make note of those, your thumb, they're forming the saddle joint and the sternoclavicular. Really hard to draw as 3D. Basically, we're talking about two saddles coming together. That looks like an absolute horrible mess. Better do it with my hands. Basically, we're saying we've got two U's doing this, so they can flex and extend and do things like that. They can abduct and adduct and do things like that, but you can't rotate one U in another U. So if we looked at our thumb and we think, what can I do with my thumb? I can do these types of movements. I can do this, but I can even circumduct, but I can't rotate it. I can't twist my thumb around like so. Same with my condyloid joints. That's why they're biaxial as well. I can flex and extend, abduct and adduct and circumduct. I just can't rotate. So an example of a condyloid joint would have been my metacarpophalangeal joints, like the base of my fingers. Example of saddle joints being the sternoclavicular joint, which is a real shallow saddle, and my base of my thumbs. Now we've already drawn the ball and socket joint. We've said they're multi-axial. There's only two ball and socket joints. One is the glenohumeral. That's my shoulder joint, effectively, my glenohumeral joint. And the second is my hip joint. In our next activity, we're going to draw the intervertebral disc. So you'll see it there labelled at the top of the page, the intervertebral disc, often called the IV disc for short, not called the Roman numeral 4 disc, which a lot of people mistakenly use. But we're talking about the disc that lies on the body. There was one of those symphysis joints that we talked about just previously. So the disc lying here on the body, what is that disc actually made out of? What does it look like? There's a space to draw below, but the intervertebral disc has two parts. It's got this round ring of collagen fibers around the outside, and it's got these spongy-like balls on the inside. Imagine that just all filled up. The purpose of these balls here is to create like the shock absorption. It's like a jelly type substance. This is called the nucleus pulposus. pulposus. Right, nucleus pulposus is these spongy little balls inside this ring of collagen fibers around the outside. Now those collagen fibers, if I were to name them, I would call them the annulus fibrosus. So the purpose here of these collagen fibers holding this in is to contain where the sponginess happens. These are going to want to expand. So the way the disc works is it absorbs shock. The ring of fibers around the outside helps to contain this from oozing out. Now this is what it's meant to look like. So nucleus pulposus and annulus fibrosus, the two sections of the invertebral disc. Now we'll see a different image of this in a moment, but what actually happens when an injury occurs is in some way the actual fibers break under load and the inside oozes out through. So this was what we would call a ruptured or a herniated disc. So the inside, the nucleus pulposus is breaking through the annulus fibrosus and oozing out. So another view of the disc here, we see the disc sitting on top of the vertebral body. You've got the nucleus pulposus with these jelly-like balls in the middle, with the annulus fibrosus with this ring of fibers around the outside. And here we see an example of that ruptured or herniated disc where the actual nucleus pulposus is broken through the annulus fibrosus. And you know, when people talk about a rupture or herniated disc, there's always a lot of pain involved. The reason for that is look at where it goes. Normally in every case it's bursting out the back because you've bent over, maybe you've tried to pick up too big a load. The disc ruptures out the back and it's running straight into those spinal nerves. So here we see a different picture here. This is the side-on view of the vertebrae, where you can see in this example the nucleus pulposus is oozed out the back, and look at that, it's run straight into the spinal cord. So really common injury, really common when people are trying to lift incorrectly under load. There's too much pressure on a certain area of the disc and the nucleus pulposus is broken out through that annulus fibrosus. So when we look at a vertebrae, there's a lot of different joints in a vertebrae. For starters, we've got the facets that are coming up here, both superior and inferior articulating facets. That word articulating means they're joints. So there's 4 facets straight up there. Specifically to a vertebrae, these facets here, where one vertebrae meets another vertebrae, is called the zygapophyseal joint. So examples of little facets, therefore they must be plane joints. Now on the side of the thoracic vertebrae, we see, hard to see, they're little tiny demifacets. These form the vertebrocostal joints, so where a vertebrae meets a rib. And finally, where the invertebral disc sits on a body and then the next vertebrae go on top, that is called the intervertebral joint. So just on this one model here, this one vertebrae, we've got a number of different joints. We've got the zygapophyseals at the top, the zygapophyseals at the bottom. You've got a rib touching in 2 places on both sides, and then an intervertebral joint where the body touches the disc and then another body. So if I were to place one vertebrae on top of another, it would look something like that. So you would see the zygapophyseal joint. These are gliding plane joints between our vertebrae. You wouldn't see these bodies touching because there would be a disc in between. And now we've just got to look at how these ribs touch. So it was actually a great story from a couple of years ago. We got to this part in the course and a student said, "Lee, I'm pretty happy with this. I know all the answers. Like I'm straight. I'm ready to go. I don't need any more." And I actually gave him this question. I said, "If you can show me how this rib attaches to this vertebrae, then I'll exempt you for the whole course." Right? That's the challenge I set to him. And he sat there and he went like, "Yeah, this is a good question." And now he didn't realise what I just did then was I switched from a thoracic vertebrae to a lumbar vertebrae, and these two things don't even go together. Right? Notice the difference here. You've got these facets facing each other. That is a lumbar vertebrae. That does not go with the rib. This one does, however. The thoracic with the facets facing in that coronal or frontal plane. We see the head of the rib touch the body of the vertebrae, and we see this little rib tubercle, the little lump on the rib touching the transverse process. So that is your vertebral costal joints, both using the same name. Now all of these rib joints here, and even at the other end, with the exception of that where that rib 1 touches the sternum, they're all plane joints. So plane, all these zygohypophyseals are plane, and then we've got the symphysis joint of the intervertebral disc. A real common error is because these are covered in so many fibers, people have a tendency to put the ribs into different fibrous type joints. Remember, you know all the fibrous joints. If it's not one of those ones on the list, it can't be. It must be synovial, and in this case, they are all plane joints. So when we've said type of joints, we've spent a lot of time on the type. We're really talking about that column 2 of our table. So, ball and socket, saddle, condyloid, that's the type of joint. But when we say name of joint, the name of joint refers to the joining of the two bones, and often it has got the names appearing in it. For example, where the sternum and the clavicle come together, that's called the sternoclavicular joint. So sternoclavicular, you broke that in half, sternoclavicular, sternum, clavicle. Other examples like the glenohumeral joint, which is the shoulder. The gleno comes from the glenoid cavity, the humeral comes from the humerus. And we see that occur a lot down. Some of them are easier than others. Some of them are just like the elbow. We just say the elbow. Some of them we see the proximal radial ulnar, radius to ulnar, at the proximal end, proximal radial ulnar. Then you've got the distal radial ulnar. Things like carpals, where you've got all these carpals on top of each other. Between a carpal to another carpal, we just call that intercarpal. So sometimes when you've got two bones of the same name, you just put the word inter. Another example we see with the phalange to phalange, interphalangeal joint. So carpals to metacarpals, carpo-metacarpal joint. Metacarpals to phalanges, metacarpophalangeal joint, and so on. So the names often go together. Now some of them are a little bit more difficult, like where the scapula and the clavicle come together, it actually comes together at the acromion. So that is called the acromioclavicular joint. So it's a little bit different because this one's using a bony landmark rather than just the entire bone. It's not the scapuloclavicle joint. It's the acromioclavicular. Also notice, it gets tricky because there's not an order. It's not always the one at the inside first, like sternoclavicular, but this is acromioclavicular. It goes the opposite way. Same with some others in the arms and legs. Sometimes it goes down, so the first name is the top bone, and sometimes it goes up and the first name is the bottom. So they can be a little bit tricky, but some of them you just kind of have to know, get through them as best you can, and we'll expose you to them over the coming weeks. But the key point here is where we say name the joint, we're looking for the amalgamation of those two bones coming together to make that name. When we say classify the joint, we're referring to each column in the table. When we say what type of joint is it, we're talking just about that second column in the table. And that's the real clear take-home message for this tutorial.